videos, and kind of towards some of your videos, you said to make sure that you, oh, sorry, thing is coming through. But to make sure that you write everything down. I didn't print your study guides till 3 days ago before my test. So I wrote everything down before, you know, I was writing every note down. So a 6-hour lecture that you did took me like 12 hours to do because I was writing everything down and like copying everything, reviewing things I didn't understand. Because the board's a little tricky because it'll ask you the question, but you really have to think about some of the answers because what you think might not be the right answer because the way they word it, they might word it 1 or 2 words just differently. And I kind of read like really fast and I was missing some of the words when I was doing the practice stuff. So I really had to stop and read the words. So I think I had a lot more anxiety than maybe needed, but your class really helped. I didn't finish the question bank. I'm going to be honest. I probably did 200 questions out of the question bank, and I bought the note cards, and I did maybe 100 out of them. I just ran out of time because I'm a procrastinator. So I really, in the last 30 days is probably when I started to study, but really over the last week and a half, 2 weeks before. So I recommend that you guys study way before. Take your time. Don't rush. Don't procrastinate like me. Just because you should the last day, just kind of chill and relax the day before and the day of, instead of trying to like cram stuff in because you really don't learn anything extra. If you know it, you know it. If you don't, you know it. But it's an awesome class. Trust the process and you're going to do awesome.
Annette, congratulations. I just have a quick question and I'm sorry to interrupt. Do they give you the numbers that you passed with or how many questions you had wrong?
No. They just so I'm from Arizona. So I said, am I going to know right away? And they said, well, it could take up to 48 business hours. So I was like, no, I need to know, did I fail or pass? Because I told my friends, it's either going to be happy tears or sad tears. And they're like, you're going to pass. You're going to pass. Don't worry about it. And then so on the way walking to my car, and I'm like, I need to check. And then there was the green check mark. And I was so relieved. Although it feels so weird not coming to your class today and listening, or having to like track like a huge book bag with my laptop and your notes and my like notebook after notebook and going to like hang out at Panera and like study all day, you know, so it's definitely weird. But also I recommend don't doing it in like 8 to 9, 10, 11 hour increments because that's how I studied. That's kind of unfortunately how I study, to do it in much smaller because your brain wants to explode at some point.
So thank you for that. I really, really appreciate it. And there are a few points that you touched that I think is very, very beneficial. One is, this is why people keep saying, where's the live review? Okay, the live review is helpful, but we do it in small videos, right? So that means you should be doing 2-3 videos a day. Your brain is not meant to do a 6 hours class like we may be doing today. So today it should be a second time around. So do it 1 hour a day. And I say eat the frog first thing in the morning, meaning, hey, wake up early and do your 1 hour, 1 hour and a half every day. If you do that, you certainly have a greater chance of passing. Another thing is learning from your mistakes on the diagnostic test. So did you find the diagnostic test very helpful?
I did, because I looked back. I ended up doing, I think I did diagnostic 1. There were some things that weren't covered in the live reviews that were kind of on. There was an extra study guide that was buried in your study guide. That there was a couple of things on there after I had taken the reviews, but I did like a 79.5 on one and an 85, and then I think I retook the number 1, which is like I think I got like an 80% on. So I kind of was, like, did I do good enough on those? But I did realize how much I learned, because I came into this class like week 4, so I didn't get to attend all the lives because you had a lot of things going on and there was things canceled and holidays in between Mother's Day and everything, Father's Day and your move and stuff. So I came in not knowing anything, because when you come in from school, you think you know something, but you really don't know as much as you think you know. So I went back and did the videos, and I tried to catch much live reviews. But pretty much what you cover in the live reviews that are taped from before is what you're still covering. Because I did notice that there was from 2024, and you have some Kahoots like on the internet and stuff. So I did some of those. So use whatever resources he has out there, because they're very helpful, and you're going to actually if you do the last diagnostic 3, you're going to see how much you learn throughout the class, because it was kind of eye-opening. But at that point, I had already been studying like 8-9 hours, so I was tired and I was making simple mistakes when I went through. So
All right.
yeah, do your small studying and do the study guide, and print the extra study guide. And you will find that there was some same questions that you had on the boards. There were some similar questions. It just worded a little differently. And then the structural family therapy is what threw me off. I had to like think about those ones for a little bit, because the way I remembered them weren't necessarily how they were posed in the question. They really made you think about it. So, but you guys are all going to do awesome.
Thank you. I appreciate you coming in today and encouraging everybody. Congratulations, and thanks again. All right, guys.
Thank you. All right, bye.
Thank you. Bye-bye. All right, guys. So it's always good to see you know, someone doing well and coming back and validating what you're studying. Okay. So you know, what she mentioned is what I've been telling you guys all the time. Please do not procrastinate. You know, do 1 hour a day if you can, and you're gonna think yourself, you only have to do this once. Okay, no one deserves to do this more than once. Okay.
Dr. Lopez?
Yes.
It's Dorothy. How are you?
Dorothy. Hi, Dorothy.
Hi. Thank you so much. I also did my test yesterday and passed.
Wow. Good.
But then,
Good.
I'm one of those people who had to do crunch down, but with your guidance, you know, I had maybe 4 days. It was a push, but I wish I had the time and the opportunity to have listened to the videos beforehand. But even with that, module 6 kind of was very comprehensive. You know, you told me just sit down and go through all the videos in module 6, and then go through the diagnostic 1 and 2, and then 3, and just review the main highlights of what you don't understand. I think that really just guided me instead of being very very anxious and trying to just know everything. I just kind of concentrated on knowing this material. And I think and not to mention the tons of videos that I had listened to you from YouTube, you know, which was just, it was like, but at the end it was more like, okay, I got that, you know. I think even though the questions seem to be, they kind of like it's easy to get the wrong answer because the way they put the questions. But once you have the materials, you also can navigate and get the right answer.
Yeah.
So this is just to encourage everybody.
Yes. And you know, make sure you ask her more questions on her WhatsApp. Dorothy, thank you so much for coming in today as well. It's a pleasure. Like I said, there was tons of people that are just passing the past 2 days. I don't know if it's Sunday or Saturday, but it was like 11 people. So you guys are really doing awesome. But please, again, guys, I beg you, please don't leave this for the last minute. Don't try to, it's a lot of material, right? We don't want to wing it. We want to kill this test, okay? Thank you again. So.
Hi, Dr. Lopez, sorry to interrupt. I'm just wondering if today's video, do we have a chance to replay it again? Because
so yeah, let me say it for you. Yes and no. I cannot record every time, because otherwise this would be longer than your course of your master's, doctor's degree, right? Because we've been doing this for a while. But what we did, we recorded the live. This is important. We recorded the live modules 1 through 5 on module 10. Please do not jump on module 10 if you only think this is helpful. What I find it helpful is bits of videos. So one subject. So for example, we're going to talk about theory. Do the modules, the video in theory, instead of doing the whole 23 videos at once. So yes, they are available. When should you watch it? After you have done the entire course and now you're like, oh my God, I want to just watch something different. Go ahead and watch something different. They are on module 10. Okay? All right.
Thank you, Doc.
My pleasure. Guys, let me keep on going. Otherwise, we're going to be here for a while. And I promise you that I'll answer any all of your questions at the end. So just please save it a little bit so we keep on going. All right. So when it comes to theories, motivation, first thing you need to know, if you ever find yourself pushing anybody to do what they don't want to do, it's not motivation. Okay, you should stop drinking because alcohol is not good for you. It's probably true, probably, I would say, right? But did the person ask you? No, right? How do you know this is, motivational? Is
Dr. Lopez, you're muted.
all right, sorry about that. So my apology. So what I was saying is that if you ever find yourself pushing someone to do something without them asking, or without them not wanting to do, this is not motivational therapy. Okay, motivational therapy is never confrontation. So what is it then? It's a non-confrontational, avoid confrontational answers. If you say you should stop drinking, and the person never asks you about, should I stop drinking? Is drinking a problem in my life? This is not motivational therapy. So motivational therapy is non-confrontational. The goal is to elicit change when the patient is ready for change. So it uses the patient-centered approach of empathy, right? Statements and empowerment. Tons of questions will come from, not tons, but at least few will come from motivational therapy. Okay, so let's start by what skills do you use for motivational therapy? ORS, OARS, which is, you need to memorize that, okay? Which is open-ended question, right? Everybody knows that. Affirmation, basic compliment to build up on what the patient is doing correctly. For example, if the patient says, yes, I have been doing, or have been going to AAA. So you can say AA meetings, right? Sorry. You can say things like, well, I'm so proud of you that you have been going to Alcoholic Anonymous class. How do you feel? Right? Reflection. So you told me that you have been going to the AA classes. What have you learned about that? To rephrasing statement or explorations to amplify the feelings and reinforce the change. And summarizing. Okay, so you have been going to the AA class. It has been 6 months. Have you felt the need to have a drink? Or what are the things that are going through your mind? Help me understand. Clarify where you're currently at. So summarizing what the person already said. So you're gonna use this acronym called ORS, OARS, open-ended, affirmation, reflection, and summarizing what the patient said. That is motivational therapy, never confrontational. So it is based on this model of things that happen in stage. Any doubts that you will see a question and ask you which stage of motivation therapy is this person under, you likely to get a question is. So let's take a look. Pre-contemplation, contemplation, preparation, action, and maintenance. Pre-contemplation. So the patient has to be ready and motivated for change to occur or to be sustained, right? So when we talked about these goals, they're very goal-oriented, require a lot of self-reflection, non-judgmental, and non-confrontation. So let's talk about those stages that we mentioned here. So your role here is based entirely on motivational interviewing, right? Which encourage the patient to adapt and sustain health-related changes. Now, when we have these stages, so let's give an example here. Pre-contemplation. In this stage, the patient does not know they have a problem. Okay? I had a car accident and I was drinking, I was drunk, but it was just because somebody walked in front of my car, right? In that case, the person is on pre-contemplation. They don't know they have a problem. They don't think they have a problem, and they don't want to change. So in this stage, you just inquire about, but you don't offer advice. Contemplation, yeah, it could be like denial. You can put that way. Contemplation is, I had a car accident and I hit somebody. I'm thinking maybe I should stop drinking. Preparation is, I know I cannot carry my life. I cannot keep going this way. I'm lucky the person didn't die. Maybe I should go to AA meetings or stop drinking. Action is, I stopped drinking. I have been I have not had a drink in 6 months, less than 6 months, more than a month usually, doing it less than 6, specifically less than 6. And I'm doing it what I said I was going to do. I'm going through AA meetings. I'm not drinking. I am going to therapy. I'm doing my community service. I'm not touching alcohol again. Minutes is after 6 months that I've been doing everything. But know that in all cases, recovery is never linear. It's always an up and down, and it's full of learning as we go. Okay? It's full of learning as we go. We learn from our mistakes. We'll go back a little bit more on preparation, pre-contemplation, contemplation, preparation, action, and minutes in the theory sections later, okay? But what I want you to know is that it is very goal-oriented. It requires a lot of self-reflections, open-ended questions for patients to elaborate. It's never judgmental. It's non-judgmental, non-confrontational interviewing. It does not include confrontations or belittling or pushing someone to do something that they do not want to do. So here are other things that you will see likely on your board, okay? The 5 A's for motivation. Ask, advise, assess, assist, and arrange, right? These are the 5 A's for motivation in interviewing. So you ask, pre-contemplation, you advise, you assess, you assist, and you arrange for service. These are the things that you do during motivation therapy. Now, frames. Tons of questions that I have seen on board preps on frames. So what's frames? Few things you need to know by the letter. I think you look at our WhatsApp group. Somebody mentioned cage. You need to know what cage is by the letter, right? You need to know what cage is. You need to know by the letter what frames is. Frames is feedback, responsibility, you advise. M is a menu of options. You do empathetic statement and self-efficacy. You need to know each one of those letters. You provide feedback, you ask them to assume responsibility, you advise, you provide a menu of choices of treatment options, you use empathetic statement, and you use self-efficacy implementations. So please memorize what frame is, and definitely also memorize ORs, right? Which we'll cover here. Okay, the 5As often, but less often comes into questions. Okay, so we'll go over pre-contemplation, contemplation, preparation in the upcoming modules today as well. So we'll do more time in there in a few minutes ahead of our today's schedule. Okay, so please make sure that you are learning this motivational therapy, because you are likely to see a question motivational therapy for sure. All right, log line, do you have a question there while I go on to the next?
Yes, I have a
modules?
question.
Please go ahead.
Yeah, I was going to ask, but today is my first day. I just signed up for the program. So I'm asking, this is module 4. I don't know how, are we going to get to module 1 or how does that work?
So yeah, so you do not, all the modules are independent of each other. So this can be your module 1, which is not, this is module 4, and you don't need previous knowledge of other modules. So what you should do is you should study on your own and catch the live classes as you can. So for example, then at some point you will watch this again on your course, and should be your second time around. Okay.
Okay. Okay. Thank you.
All right. Yeah. So Vinny, same thing for you. Now, remember I said that motivation therapy use the framework of this trans-theoretical models of changes, and I didn't want to spend lots of time because we are also spending time here, and it's called the trans-theoretical models of a change. Okay. In these 5 stages, important that you know, because you will get a question, and the question will say, which likely stage of motivational therapy is this person on? Or sometimes they'll say, which stage in the trans-theoretical model of a change is this person on? Okay, pre-contemplation. I don't have a problem. I don't need no advice if I don't have a problem, right? You're not going to give me one because I don't have a problem. So no initiation. One quick second. So in no initiation, one second. Let me just get off my own. It's making a noise here. I don't know where is that coming from. Just want to make sure that it's not me. So if somebody didn't ask you for an advice, don't give one in pre-contemplation. No initiation of change. They don't think they have a problem. So your action is to provide feedback to raise awareness. For example, do you think alcohol is a problem in your life? I'm not saying it is, or it's saying that's not, or that they should quit. I'm just saying, do not give advice. Your goal here on pre-contemplation is to create awareness. Okay? Contemplation. In this phase, they are partially or fully aware of the behavior, but they're not committed to change. They think, I think I should stop drinking. But they did not stop drinking. Right? So the action here is to see the benefit of change, of the consequence of not changing the behavior. The benefit of changes versus the benefit of not changing the behavior. So next phase is preparation. The key here is making plan. As long as they say, I am going to AA class, they are on preparation phase. They're making plans. So between contemplation and preparation, contemplation, they're thinking about it. They're not fully committed. Preparation, you're making plans to change if the patient believes he has a problem, right? So what you do here is find realistic resources for change. Here are the meetings. Here are the resources that you can do. Now, once they start doing it, they are on action. The patient is taking action to change. For example, they're now attending AA meetings. So the provide encouragement, the specific advice to continue the change. And the final stage, meaning that for over 6 months, they have been doing what they said they were going to do. Now, question that I always get is, let's say someone had a relapse, right? And they start drinking again. Which phase are they in? So it depends on the question, right? Do they have a relapse and they think they don't have a problem? Then there will be pre-contemplation. They have had a relapse, but they are thinking about going back to the meetings. They are in contemplation. They had a relapse. They said they are going to do it, and they start making plans on rehabilitation. They are in preparations. They had a relapse, but they got up again and started going to the meetings. So they are in action. And obviously, they're not in minutes because they has to be over 6 months. Okay? It's important that you take time. So here on your white piece of paper, not so much is the reason for the white piece of paper that we covered today, it's more for the family therapies. You should at least trust theoretical model of change, and you should put in those 5 phases. So it helps you anchor pre-contemplation, contemplation, preparation, action plan, and maintenance phase, not a plan. Okay? And then you should be able to say what they are and give an examples. So that way, when you get a question, you can be like, okay, I learned this. They are making plans. They're not making plans. They don't want on a device. They think they have a problem. They don't think they have a problem where they are at. So this way it can be a bit confusing, right? But the more you start putting those things into ways of remembering, the easier it will get. Ingrid, do you have a question there?
Yes, Dr. Lopez. Okay,
Please.
I'll make it quick. So my question number 1 is Sigmund Freud's mechanism of defense the same thing as the psychoanalytic theory?
Some would say yes. No, hold on. Freud's mechanism of defense. I thought you were going to say psychoanalytics versus psychoanalytics. So answering your question first. Yes. So the mechanism of defense often is related to Freud's.
Okay. I was just asking because yesterday I watched the video and all these terms come under the psychoanalytic theory. I just don't want to get confused or confuse anyone else.
Yes, they are because it's called the Fyodor defense mechanism. Yes.
Okay, thank you. And the second question, real quick, these interviewing techniques or therapy techniques like frames and also the trans-theoretical, are these techniques that we can use with motivational and also with the family system or structural system or any therapy?
No, so that is motivational therapy in itself. So it's a modality in itself. It's called motivational therapy.
All right, thank you so much.
But can you use it in anything else? Yes, you can mix and match. Once you are skilled, you can use cognitive behavior therapy as you are doing you can mix and match all that, so it becomes part of your tools. But specifically here, more related is motivational change and trans-theoretical, because you can see how they kind of relate under one another.
Okay, thank you, Dr. Lopez.
Okay, no, my pleasure. So if we look at the blueprint for ANCC, you're going to see Lewis change theory. Now, I have never seen a student mention that. So I don't know if this would be on your board or not. We're teaching for you to pass the board here, right? So, but I'm covering it because it is on your blueprint. right? They stated, I get all this stuff from the blueprint, but I can tell you that I haven't seen so much, but I still want to cover just in case. When you think about Lewis changes, theory of changes or change theories, right? Think of this as a three concept: the driving force, the equilibrium, right? The driving force, the equilibrium, and the restraining. So let's put it in a simple way. What's the driving force? The driving force is, I like to say, people only change when the pain of staying the same is greater than the pain of changing. So you can do this as a driving force. The driving force are those that push in the direction that cause a change to occur. The restraining force is what keeps the change from occurring. So the forces are the forces that counter the driving force. And the equilibrium is the what's in the middle between I need to change, I don't want to change, it's too, I have to do too much to change. Then you have your equilibrium. It's what's in the middle. So it's a state of being where the driving force in the equals to the equilibrium. The driving force is equal to the restraining force, so therefore there is no change. Okay? Also, it comes into when it comes to change, you hear the examples of unfreezing, change, and refreezing. So what does it mean? What does it mean? When you say unfreezing, it helps the patient get off of the patterns that were somehow counterproductive by increasing the driving force and decreasing the restraining force, and the combination of the two methods. So there is the change. So that's called the unfreezing towards the driving force. The change is moving to a new level, or a movement that involves a process of changes in thoughts, feelings, and behaviors, or all three that is in the same way more liberating and productive. So you go from unfreezing to sustaining the changing. Now refreezing is establishing the changes as a new habit, as in, let me give you an example. So the unfreezing, so the patient gets off of what was counterproductive. For example, let me see, for example, a student does, going through this phase of unfreezing, change, and refreezing. So what was counterproductive? Starting late at night when someone is tired. That is counterproductive. The changes now are moving to a new level of movement where involves a process of changing thoughts, behaviors, and actions. For example, by saying, hey, I will not study at night because at night I'm tired. I want to study early in the morning. And the refreezing would be establishing the change as the new habit. Every single day I wake up at 6 in the morning and I will study for 1 hour. Okay? So makes sense. I hope. Hopefully it does a little bit. Don't complicate too much. And I don't want to spend too much time here because, again, I'm only covering because it's in the blueprint. That means there could be new questions coming up on this subject. I don't know. But I haven't seen a lot of people talk about Lewis' stage of change. Rarely, if ever. But when the ANCC did the new questions, the new change to their model of testing, they put this in the blueprint. How do you know the blueprint? Well, it's in their website. So all the stuff that we get from the course is coming from their website. In addition to what I know, what are the traps are, we use that to make a course that is effective for you. Okay? All right. So what's next? So here we are going to talk about cognitive behavior therapy. No, cognitive therapy, behavior therapy, and the combination of both. when we say cognitive therapy, is only the mind. Okay, so let's see what I mean by that. So this is the cognitive portion of it. So when we say cognitive, you need to know who created cognitive therapy. Only few people, only few names are in my presentation. If they are in my presentations, you need to know. Okay, so Aaron Beck created cognitive therapy. So what's cognitive therapy? It's only the mind, the change of irrational beliefs, negative thoughts, and cognitive distortion. Thoughts and behaviors influences our feeling, right? So if we can change our thoughts, it influences our behavior, which influences how we feel about things. So a treatment process that allows the patient to correct their false belief or distortion or distorted thoughts and perception that were responsible for the negative moods, behaviors, and anxiety. But here, it's all about the mind. And it's going to make sense on the next one, on the next slides, where we put the behavior, which is the modeling, the doing. Right now, is just challenging the negative thoughts. So let's give an example. Perfect example. Someone said I was ignoring him, that I was not answering his question on WhatsApp, or, could that be that I receive 200 messages a day? Could that be that many other options? Was it true that I was ignoring the person, or could be something else? So when we look at cognitive behavior, we change those patterns of negative thinking and switch them to a more reasonable fact base. Can we evaluate what else was happening in the situation to make a concrete statement if it was absolutely ignoring, or there was other demands that was happening and that perhaps I couldn't attend to their needs, right? So when we say cognitive, it's all about the distortion in the patterns of thinking, thoughts, and behavior. So if we can change those thoughts, we change how we feel, we change our behaviors, and we have better outcome. So that is it for cognitive. So when we marry the cognitive with the behavior, right? So let me open up the other modules here real quick. Now it's a great time, if you have a question, to ask. Okay, well, I open up these modules here. There's tons of modules today. Okay. Go ahead, ask your question if you do have one. Oops, that's not it. That's 19. If you do have a question, please ask. If
Hi,
not,
Dr.
it's okay.
Lopez.
Hello there.
I know it's not dealing. I'm going to take my test on the 16th. I emailed you, and
Yeah.
I feel.
Don't worry too much about it. You may have to retest it. I mean, you may have to reschedule, but we'll come up with the. Is this Francis?
Yes, Francisco.
Okay, Francisco. Okay, so what we're gonna do is give you a task. If you feel that perhaps, if we feel that we can get close, we'll go ahead and I will advise you to test it. I'll give you the tools that you need to even try to wing it. But honestly, it's going to depend on where you are after you test it. Okay, because I don't want to lead you in the wrong way, because it's coming up the 16th and you are about to join us very soon, right? So does it sound reasonable?
Yes.
Because the problem with testing and not passing is that we all develop this, oh my God, am I going to be able to pass the next time? Right? And we don't want to be so far back where our minds is pulling tricks on us. This is very, very stressful. So what I'm going to propose to you, I'm going to write you an email after today's event. We can talk a little bit more. Is give you a task, and depending how well you do on the task, we can suggest whether you have enough time or not. Because I don't know what you have done so far. Does that make sense?
Yes.
And
Thank you.
believe me, I never tell someone they should test unless if I know that they will pass. But I tell plenty of people that, like, hey, if you will pass, because I have 100% confidence that you
Me-
will.
Dr. Lopez, I am scheduled the same day to take my test as well. I
Yes.
did the diagnosis 1 and 2. I'm still doing the review on my weaknesses. So do I need your test you talk about again?
Well, it depends on what was your score. If you score like above 75, that means you have a great chance of passing. If you
I
score,
just missed 174 point something.
I think you'll be okay. By the 16, you should be fine.
Okay, thank you.
Okay, but we'll make sure that on the crash course review, there is the document that she mentioned. The first person, Mrs. Annette mentioned. There is a lot of things in the document that's highlighted that you should know. You should really know, and
Yeah,
you should go.
I save it in my computer. I have it. It's like 73 pages. The highlight
Yes.
stuff. Yeah,
Mhm.
I've been reviewing it too. So I'm working on it, and then now I'm doing a lot of questions too. The questions I'm reviewing the questions. So yeah.
Okay, we'll talk
Yeah.
more offline, and we'll get you the best as possible ready for the test. Okay,
Thank you,
and we'll
doctor.
talk. Yeah, and we'll talk more, Francisco, offline as well.
Thank
So
you.
one thing you need to know. Well, I'll wait for the next slide. When you have the cognitive, it's just the thinking. You're not doing nothing else. You just changing the negative pattern or distorted thought process and installing new ones, but you're not doing an exercise. When you're doing something, that is behavioral therapy. So here the goal is to change maladaptive behaviors with positive ones. Cognitive is changing maladaptive thoughts with the positive ones. Guess what? Now when you marry both together and you have cognitive behavior therapy, which is the third modality, right? So here, when it comes to behavior, so you have to do something. So what is that? It's an action-based therapy that is based on the notion that all behaviors are learned and can be changed. So how is that? Exposure therapy, relaxation, modeling, role playing. That is behavior therapy. So if you find a question that is asking you to do something physically, it is behavior therapy. So exposure to a given a lecture and you're pretty nervous, the more you do, the more you role playing, the better you get at it, right? So problem solving something, it is behavior therapy. Okay, so I just want to put that together. So Aaron Beck is the father of cognitive behavior therapy. So this type of therapy has two aspects. It replaces the negative distorted thoughts with the positive thoughts. It also combines the benefit of problem solving, skill training, modeling, exposure, role playing to give a more effective tool for depression and anxiety symptoms. An example is using daily logs, high yield. In cognitive behavior therapy, we use diaries. If the question has diaries, it's something that you do for cognitive behavior therapy. So here says daily logs of symptoms, diary, and journaling to reflect on and improve experience. Which therapy is that? So I give you the answer. This is cognitive behavior therapy because we have replacement of negative and distorted thoughts with positive ones. So that's the cognitive portion. We have the modeling portion or the behavior portion, that's skill training, modeling, exposure, role playing. And the third part of this question has something that's super high, you journaling, diaries, daily
I don't
logs
see the
of
screen.
symptoms.
I don't see the screen.
We cannot see the screen, Dr. Lopez.
Oh man, sorry. Here we go. Okay, sorry guys. You guys got to keep me on track here. So let me go back here real quick. So here we talked about the cognitive portion. We talked about the behavior. Now, when we marry both together, we got cognitive behavior therapy. Aaron Beck, again, is the person who created cognitive and the person who created cognitive behavior therapy. Okay? So when we do cognitive behavior therapy, we aim to change patterns of our conscious and unconscious belief and behaviors to overcome problems. High yield, journaling, daily logs, and cognitive restructuring. And who created? Aaron Beck. Okay, so here's the question. This type of therapy has two aspects. So we know it's two therapies. It replaced negative and distorted thoughts with positive thoughts. It combines the benefit of problem solving, skill training, modeling, exposure, and role playing to give a more effective tool for depression and anxiety. An example is using daily logs of symptoms, diary journaling to reflect on and to improve experience. Which therapy is this? Interpersonal therapy, experimental therapy, cognitive behavior therapy, or humanistic? So this is cognitive behavior therapy. I want you to highlight this right now before you forget. Journaling and cognitive restructuring is high yield for questions that comes with cognitive behavior therapy. Okay, another thing that's high yield that's going to cover next is, okay, I'll wait for that. Interpersonal therapy. Interpersonal therapy is when there are disagreements in between two parties, husband and wife. Are you going to pick couples therapy? No. If the question says disagreement is interpersonal therapy, even though it's couples. Okay, we'll cover more about humanistic coming up. Cognitive behavior therapy we just covered. Aaron Beck.
Excuse me, Dr. Lopez.
Yes.
You said disagreement is interpersonal.
Yes.
If it's a disagreement.
Disagreement. Anytime you hear disagreement, this question gets a lot of people all the time because option A will be couples therapy.
Okay.
But if the question says disagreement, is interpersonal therapy. Okay?
All right, thank you.
Disagreement between co-workers, interpersonal therapy. Disagreement between husband and wife, interpersonal therapy. Okay, so this is again is the notion that hey, if we can change the thoughts, we can change how we feel. And if we change how we feel, we change our behaviors, which will change the physical reaction. Okay. It also uses things like Socratic question. What is Socratic question? Someone may ask me, how do I respond? What do you think Socratic question is? So basically, I'm going to reinstate the question that the person asked me in order to elicit a change or a answer. Basically, having them think. But what's high yield here is journaling. It is the marriage of the cognitive portion, the behavior portion. Combined, we have cognitive behavior therapy. And who created? Other than that, these are the things that come up on tests all the time. Okay, guys, if we cover anything in our lectures, whether it is on a crash course review, one of these lectures, you are likely to see on your test. Okay, so one of the things that we do is we don't spend time on things that you don't need to know. Obazi, do you have a question there?
Yes, I have a question.
Yeah, go ahead.
You said interpersonal theory is all about disagreement. And I know that interpersonal therapy is also used as a form of non-pharmacological treatment for depression. So how does it work here?
So interpersonal therapy is about disagreement, right? And can be used in many different levels. So one feels depressed because they cannot get along with somebody else. So what I did is maybe like 7-8 years ago, I had two nurses that hated each other. They just hated each other, and they assumed I call it office in charge of the unit, and they just couldn't work together. They could not be on the same shift. They could not see each other in the same hallway. And I had what I did. I put them every Monday, one in one side of the table, the other one on the other side, and I called the third party. And I didn't even do a thing. I just stayed there, and I let the third party hash it out what it is the problem, right? So now, can that be used for depression? Yes. Is it usually used for that? No. Does it answer your question?
Yes.
Because basically you're trying to find the common ground in which the person's feeling depressed because of that situation. This is how interpersonal therapy can be used for depression, in essence. Okay. All right. So if you think Ironback is high yield for the test, wait until you see Marsha Lineham. One quick second. Until you see Marsha Lineham. So that is likely to be in your test. So who's Marsha Lineham? In fact, she's actually having a course of DBT. So Marsha Lineham is a doctor that created DBT, dialectical behavior therapy. Who is it for? Borderline personality disorder. So need to know who is Marsha Lineham, which therapy she created, dialectical behavior therapy, and what is the goal of dialectical behavior therapy. So in summary, the goal of dialectical behavior therapy is to decrease crisis. Okay? Decrease self-injury behaviors. This is important. Oftentimes it is asked who created dialectical behavior therapy, who is the population that benefits the most from dialectical behavior therapy. is borderline personality disorder, and what is the goal of dialectical behavior therapy? It is to decrease crisis. So now it is much more than that. So there is an acronym which is called DC steps. So the goal of dialectical behavior therapy is to DC, so decrease, right? Decrease what? Crisis. And the also decreases the crisis generating behaviors. That is the steps, right? Suicidal thoughts, therapy interfering behavior. If you put 12 borderline person in the room, it is very difficult because everybody will be asking questions, everybody will be lifting their hands, everybody will be fighting. So they need to decrease therapy interfering behaviors, decrease emotional reactivity, decrease passivity. Oh, nobody wants to let me talk, I'm just not going to talk anymore. And decrease self-invalidation, invalidating behaviors. And you want to increase what? Decision making and communication. That is a lot. If you don't want to memorize this acronym, I don't blame you. No. Dialectical behavior therapy, Marshall Lyham, and the goal to decrease crisis, decrease suicidality, decrease self-harming behaviors. May I? Okay. You review her medical records. You review her past diagnosis. And borderline personality disorder is one of the diagnoses that is listed in her record. You do your assessment and you agree with the diagnosis. What's your next action? What do you refer the patient to? Would you refer the patient for dialectical behavior therapy? Would you prescribe fluoxetine? Would you refer the patient for interpersonal therapy? Or would you refer the patient for existential crisis? So again, because it's borderline, then dialectical behavior therapy is the answer choice. Did you know, not this question, that the therapist needs therapy after each round of completed dialectical behavior therapy? It is intense. It's very restrictive. Everybody starts here at 8 o'clock. We're not going to push this until 8:05. No one needs to talk when there's not time to talk. It is very restrictive because it is hard. At the end, the therapist will need to have therapy before they can do the second round or second interaction of a new patient. Just a fun fact. Can someone please read this question? Anyone will be so kind?
Mr. Ashton is a 24-year-old female patient who has a diagnosis of borderline personality disorder. She was referred to dialectical behavior therapy a few weeks ago. During the appointment, she told you that the DBT has been helping her tremendously. Knowing the constructs of DBT, what is the one activity related to DBT that might be helping Mrs. Ashton? A, remembering past events to conduct a life review and revisit moments from the past. B, keeping a diary or a journal to keep a record of exhibited behaviors, responses, and triggers before and during outbursts. C, evaluating social interactions to assess negative patterns to work on relationships with others. Or D, exposure to triggers in a controlled environment to decrease ritualistic behaviors or anxiety related to the exposure. Okay.
That's a hard one because I didn't cover what you need to.
Yeah.
Please.
But I would say, so DBT, I'm gonna go with C, only because of the social interactions.
Okay, all right. So evaluating social interactions to assess negative patterns to work on relationships with others. So not. Okay, so I see why this question is hard. Do you remember when I said that journaling is high used for cognitive behavior therapy? Here, high yield for DBT is diary and journal record keeping of their emotions and behaviors response and what triggers them. Everyone highlight that. That is likely to be on your board. When you hear keeping diary or journal for DBT, right? Because we want to know, okay, you exploded. So tell me what happened during this behavior response. What triggered you during this outburst? And review and reflect on the entry. Could you have done something differently? So diary, journaling, keeping records of the outburst is high yield for DBT. So how is that different than journaling with CBT? With the CBT is more of a, hey, how did you feel during that moment? Here is more for us to identify what triggered you. Yeah, it is a little confusing, all right? But it's because I didn't put in the slide here. I should have probably, put it this in the main slide. But nevertheless, it's something that you absolutely needed to know, okay? So we want, with DBT, know what trigger the emotion and the outburst, and we want to reflect that. Okay, so please make a note of DBT. You should write this down. Journal record keeping for DBT. Oftentimes we ask this for the patient in real life. Okay, keep a journal. I just want to kill the person, blah blah blah. Keep a journal of when you have those emotions, so we can go back and analyze and rephrase it, reframe it in a different way. Okay, very high yield. So when you think about DBT, I could say Marshall Ham, borderline personality disorder. For DBT, the goal of DBT to decrease crisis, suicidal behavior, and journal record keeping. These are the 4 things you really should know about the DBT. Okay, so we're keeping as simple as possible. I know it's a lot of content, right? But giving you the most high yield of each one of that. So it is, you guys want a break? Or should I keep on going? What do you think? Anybody cares whether we'll have a break or not? I can keep on going all night.
Keep going.
Keep going. All right, let's do this.
Keep going.
All right. Let me open my slides here. So perfect. I actually got it luckily here. It is number 12. Okay. So now here is where a lot of people get this confused, but you
Your
won't.
screen is not sharing.
Yes, I'm sharing right now. Thank you, man. This is about existential therapy. So who would benefit from existential therapy? What's the reason for my living? Those people that are in crisis. Doesn't matter if I die or live, or those that have cancers or a terminal disease, and they kind of reflect on their existence, right? So it's about issues of existence, right? So when questioned, it's about issues of existence to understand the patient's subjective experience, focus on the present and personal responsibility. So if with motivational therapy you never confront, you do with existential therapy. So, who are the patients that would benefit from this? Terminal illness, right? Cancers, HIV, things like that. Suicidality patients, crisis in life transitioning or transitions. And we ask them to reflect on life and subjective experience, right? So I had a patient that said to me that if I die, my wife would just find another husband and life would go on. So I would say, tell me a little bit more why you feel this way. Or do you know that fathers that are actually do harm themselves and end up dying, their daughters or kids are twice as likely to follow the same behavior? How do you feel about that? Right? So I'm using self-confrontation here, right? In a slightly twisted way. I'm confronting, but I'm reflecting. So self-confrontation is encouraged by reflecting on their own life. You know, what do you think would happen if you were no longer around? Do you think that your daughter would feel, what's more important for you, you know, for your daughter? You think it's having this big mission or having you at the house being a father, right? What's the reason for your existence? That is in a nutshell, existential therapy. Okay, so when you see existential therapy, think of it as the reason for the existence of the patient, and confrontational. So, I mean, you know, don't take it to extreme, right? But it is a little bit more of confrontations so that they can be able to rationalize through their thoughts and emotions. Okay, not super high yield, other than, hey, for those with suicidality, sometimes it can be helpful. For those in crisis, terminal illness crisis, it can be helpful. Sometimes even those with depression, sometimes it can be a little bit helpful, but you gotta know how to use it in order to be effective. Okay. All right. So now let's see the next module. Let me go ahead, ask your question. If you do have a question, please.
Yeah, I was wondering if you can differentiate the logotherapy from this existential therapy.
Yes, we are going to, when we get to Gestalt, which is similar to log therapy. So we're going to talk about that in a second. Okay, so we are at now. So when we say humanistic is the big umbrella, and under humanistic comes Carl Roger. Oh, wait a minute, that's another name you need to know. Carl Roger is person-centered therapy, and it's so closely related to humanistic that people even call it the same thing, which is not, but is acceptable if someone may call it that. So basically, think of a humanistic. Here are the things you need to know. Humanistic, think of it as Carl Rogers, which humanistic, put it slash person-centered therapy. So you need to know Aaron Beck, you need to know Marshall Lineham, you need to know Carl Rogers. Carl Rogers can be said as the father of a humanistic or the father of a human person therapy. Human-centered, sorry, person-centered therapy, not human-centered. Why? Because only humans can self-actualization and self-directed goals. What do I mean? Well, if you look at Maslow hierarchy of needs, the pyramid, right? At the bottom, we have food, water, shelter, reprocreation, safety after that. And on top of the pyramid is where you are today. You are here because no one's shooting at you. You're here because you have food on your table. You're here because you have shelter. You may have a little bit of an extra student loan, but that's not, like super life needing substance. Okay. So what we're trying to say is that you are on the top of the pyramid right now. And that is humanistic. You can only think of self-actualization, self-directed goals when you have met the bottom of the pyramid. High yield, high yield, high yield. Only humans can have self-directed goals, meaning you want to graduate your master's or your doctor's degree and you pass the board. You have self-actualization, right? So only humans deal with higher functions such as self-actualization, self-directed goals, finding the meaning of life. So one would say that Carl Rogers' person-centered therapy is the such of a therapy that there is no notes. It's simply listening, non-directive insight therapy based on the work of Carl Rogers, in which the client does all the talking and the therapist listen, right? They do reflection, unconditional support, yada, 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 not important for the board. What's important is Carl Rogers, humanistic, person-centered therapy, self-directed goals, self-directed goals, and self-actualization. Okay, so now when we look at the question here, this type of therapy is a form of talk therapy with Gestalt approach. So humanistic is the bigger umbrella. And under the umbrella, we have logotherapy, we have Gestalt, we have person-centered therapy. They're all about self-actualization, right? That focus on the present. It emphasizes the importance of being your true self and lead a fulfilling life. That's what we're doing. We're fulfilling our lives with the higher skills. The concept of free will, human potential, self-discovery, self-directed goals, and self-actualization. So you know now this is humanistic therapy, Carl Rogers, right? And are central to this theory. Which of the following therapies is this? Interpersonal, existential, cognitive behavior therapy, or humanistic? So obviously it's humanistic because we discussed, but if the same question had person-centered therapy, it still would be true as person-centered therapy. Okay? Guys, if I'm repeating myself 10 times, it's because it's important, okay? So humanistic, person-centered therapy, only humans deal with higher functions such as self-actualization, self-directed goals, and finding meaning. And we can only do that after our needs, basic needs are met. Which type of therapy emphasizes self-directed goals, self-actualization is the key concept? Is that behavior therapy? Is cognitive behavior therapy? Is that person-centered therapy? So it's the same question as the before, but instead of saying humanistic, here was mentioned as person-centered therapy. Please make a note of that. Humanistic / person-centered therapy, self-actualization, self-directed goals. also known as Rogerians because it's Carl Rogers. If you have a hard time to remember, I make fun of this because I just do. Think of the Mr. Rogers, right? Who wants to be my neighbor. So I always think of that, right? So here we go. Person-centered therapy, known as Rogerian therapy or sometimes humanistic. Okay, so I also, did I put an acronym here? Maybe, maybe not. Gestalt. So think of Gestalt. It falls, you don't need to know this name here, okay? Gestalt falls under humanistic. It focuses on the present, just like all the humanistics therapies. It emphasizes the empty chair dialogue and hope role-playing to help clients under their current feelings, understand their current feelings and needs, emphasize personal responsibilities. Clients are encouraged to take ownership of their choice and actions. Techniques like being present. All of the humanistic therapies are being present. Role-playing, unfinished business dialogue help clients gain insight into their own experience and behaviors. So all what I'm trying to say is that the humanistic is a big umbrella. Under there, we have Carl Rogers, we have Gestalt, and sometimes also kind of looking here at Gestalt therapy and humanistic. How are they similar or different? So both of them emphasize the concept of Gestalt or understanding human as a whole. Both of them advocate for focus on the present. Both of them look at the influences of the past on the present. And both of them encourage individuals to be responsible and self-awareness. Now, how are they different, right? So, we're gonna go on the difference here. So, mainly, just humanistic is just a bigger umbrella, while Gestalt is more of a whole life review. One could say that. Okay, so we're not going to, let's see if we got more questions here. Okay, let's see here. Okay, we covered this, covered that. See if we cover this last question. Which type of therapy emphasizes self-directed goals and self-actualization? Carl Rogers, Rogerian, humanistic. We call it the same thing for the sake of the test. Okay. So we'll go back in the logo therapy in a little bit. Okay. I'll owe you that one so that way we can keep on moving. Here we do have quite a bit to cover. This where I'm saying as in, hey, you should not wait to learn only from the live classes, because if you do that, it may be a little bit too fast for you to digest. Okay, Cecilia, you have a question there? Not sure if you do.
Not anymore. You answer it. My hand is still open. I'm sorry.
Okay, no problem. Now, here is a therapy that gets a lot of people confused, because often the question comes with couples therapy. I put this on my Facebook, and every single time, no matter if I just put the question 2 days earlier, 50% of the people get it wrong. Okay, so interpersonal therapy, you don't need to know Kleiman and Weinman. Address interpersonal problems, mitigate conflicts to alleviate distress for clients, concentrate on solving interpersonal conflicts. IPT, which is interpersonal therapy, emphasizes on the interpersonal issues as a source of distress. And here is the why. It can be effective for depression, even eating disorder, Are you overeating because of the stress? Even substance use, right? Or marital discord. And everyone goes straight to couples therapy, right? When you see marital discord. The answer is likely to be interpersonal therapy. Is a time limit, present, focus, dialogue, diagnosis, target, intervention, spanning between sometimes 10 to 16 sessions. Concentration on the here now, just like all the humanistic therapies, to solve issues related to identified problems areas. Okay, so interpersonal therapy aims to improve interpersonal relationships. Now you can see why it can be helpful for couples, right? It follows a holistic approach that has an underlying assumption that the past and the present relationships of a person plays a role in the origin of arising concerns. The goal is to improve relationships. So this is why it's not couples therapy, but interpersonal therapy, and change the expectations surrounding the relationship. Can be specifically helpful for clients with relationship, marriage problems, again, and concerns. I'm emphasizing on making this super easy as we look now. But watch the same question or similar question show up on your test, and some of you guys taking couples therapy. Hopefully not. Hopefully I'm totally wrong. I would love to be wrong. Absolutely love to be wrong. So 30 days later, 40 days later, 60 days later, you're testing for the board. Which therapy approach might be helpful for individuals seeking to improve their ability to navigate conflict with others, spouse, or the spouse, they're fighting consistently? Choose, I wouldn't tell you co-workers because that would make it so easy, right? And then option A will likely be couples therapy. Okay? Would that be dialectical behavior therapy, Gottman methods, cognitive behavior therapy, interpersonal therapy, or solution-focused therapy, right? So we know this is interpersonal therapy. Okay, so another thing that's likely to be on your board. Let's say you have a couple and they've been doing therapy and you are the therapist. And they're scheduled today to see you. The wife shows up alone. Which of the following options would be the most ethical to do, or would you like to proceed with? See the wife since she's here today, A. B, release the information pertaining to the husband since they are wife and husband. C, reschedule the therapy. Or D, do a round of cognitive behavior therapy to better understand the distorted relationship. Which one would you pick? Reschedule. Reschedule. If you are doing a therapy as a couple, not to say this is a couple therapies, you cannot see one party without the other. Please ask your, this is an important concept that I'm explaining, so it's important that you guys get that one, okay? Please go ahead, ask the question.
Yes, I wanted to say I do understand the whole concept of rescheduling. However, what I've seen or noticed is if only one party is showing up, sometimes the therapist takes the time to work with maybe the wife on issues she herself is having.
Now you are doing real life.
Okay.
People, you know, their motive for billing right? Now, if this is, you're working with a couple and only one shows up, you have to reschedule. This is a board question likely to be on your board. Okay, so we all, including myself, have a tendency to draw from my own experience when I'm solving problems, right? But we have to understand real life board questions, ethical dilemmas in between, right? So if it's couples therapy, if you're working with the couples or interpersonal therapy, whatever it might be, and you're working with the two parties, you cannot just listen to one. You cannot release the information to another just because they are married or so forth. So for the board, when you get a question that is couples therapy, you reschedule when only one shows up. All right. Again, we're, this is not necessarily, your hospital may have a different policy. It may be understandable why you don't want to, you don't want to reschedule. But for the board, remember, the board, everything is perfect. You got the time to call the nursing board association. You have all these, yeah, you get paid and all that, whether you did the work or you didn't, as long as you're there. So all things are perfect, right? Now, real life, do what is ethical and that the company that you work for tells you to do, as long as. So please mute yourself there if you are on, so that way we can keep on moving. Somebody has a hot mic. Don't want you to hear your conversation, especially if you don't want us to hear. All right. So now let's talk about a very important concept is Maslow. And it's not just because the top of the pyramid, only humans can self-actualization concept for humanistic or Carl Rogers, but because how to answer your question has to do with Maslow. Anytime on your board you have priority, prioritization, what things you should do first, always follow these three principles. One, airway, breathing, circulation. And 99% of the time is not about airway, breathing, circulation, so we can take that out. Two, Maslow hierarchy of need. Is it about safety? For example, let's say you are seeing someone that just been raped and she's in your office and she disclaimed this to you, right? So now it is not about collecting a rape kit. It is not about punishing the person that did this. It's about, do you have a place, a safe place to go home tonight? Right? And that is Maslow. When we look at Maslow, we look at the bottom of the pyramid: food, water, warmth, sex, reproducing, then safety. If the question is about what you should do first, your priority, ask yourself, is it airway, breathing, circulation? No. If it's not, if it is, then that is the answer. If it's not, is it about Maslow? So what's Maslow? Safety, security, right? Safety can be a medication that could cause birth defect. Safety could be, do you have a safety place to go home tonight? It is about Maslow, right? And look at the top of the pyramid: self-actualization, achieving one's full potential, including creative activities. This is what you are now. You're the top of the pyramid. Now, if it's not about airway, breathing, circulation, if it's not about Maslow, so now is the nursing process. So what's the nursing process? As a PMHNP or practitioner, family practitioner of any kind, anytime you look at the research you're collecting data. Anytime you are asking for labs, that is not an intervention, that is collecting data. So anytime you're doing numbers to make up your diagnosis, that is the nursing process of assessment. A little bit different, right? Because if I said, I would like to get vitals, you RN would say this may be an intervention. For us, it is the collection of information so that I can make my assessment. So airway, breathing, circulation, yes or no? Maslow hierarchy of needs, safety, food, water, yes or no? Now the nursing process. Nursing process, collection of data, whether it's looking at the research, whether asking for a lab, that is an assessment, whether it is vitals, that is an assessment, not an intervention. Okay, so let's take that out of the way. Now let's go back to Maslow. Maslow is poised that human needs are arranged in hierarchies. As I mentioned, all of you guys are, none of you guys are, you know, someone's breaking through your house right now. I hope not, all right? You are safe. You have food, water, and shelter. So now you can, guys, I passed my board on Saturday. Bridget, congratulations. Sorry, I saw your email and I really want to respond as probably as soon as tomorrow since we finished early. But thank you, Bridget, for saying that you passed the board. Listen to Dr. Love. Wow, that's nice. Should you really? But anyways, so thank you, Bridget. I really appreciate that for sure. Yeah, guys. So tons of people pressing the board. Tons of people, right? Now, some people may not pass because of one question, and that comes down to the things that I've been saying to you. Please do not rest on your laurels, okay? Do the work and you will pass. Do the work and you will pass. Listen to what I'm saying here. I'm not trying to repeat myself for no reason, right? Yes, do the work, please, because you will need it when it comes to the board day. Okay, Maslow points that your basic needs are needed before you can self-actualization. Carl Rogers, right? Humanistic. So they're organizing hierarchies of prepotence in which the basic needs must be met before you think of a higher needs. Sure, they don't have to be absolutely hierarchies. As long as in the middle here, sometimes we can neglect self-esteem, right? Towards the top of the pyramid, things get a little bit, you know, convoluted. But the basics of it, the bottom three, they kind of need to, you know, at least the bottom two, they need to be met before we think about getting a better job. We need to have food first, right? So think about the biological, physiological, safety, belonging, self-esteem, and self-actualization. Said that 10 times. It will be on your board, I promise you. That's why I'm saying 10 times, okay? So, I mean, I can't promise you because, you know, I don't know that, but specifically, but I've seen this on and on again, okay? So here we go. Now, next thing. All right. So eye movement therapy, okay? Will be on your board that. Can promise you that in one way or another. So what is eye movement therapy? Treatment for PTSD. Sure. Is that what it stands for? No. It's eye movement desensitization reprocessing. So in my office, I have a light. And I sit down my patient and I say, look at the light. And we go through the stage of reprocessing of what happened slowly. And to whom or which population do we use this to? PTSD. The goal is important. Why do we do EMDR? To achieve to achieve adaptive resolution. So what is that? Well, to overcome our previous problems that was traumatic. So that means the goal of EMDR is to achieve adaptive. We know there was a problem. Can we adapt? Resolution. Important. Just like the goal of other therapies that we cover today, you need to know the goal of EMDR. Highlight that. Achieve adaptive resolution, right? So there are several phases of EMDR. 3 of them I am interested. The rest don't really care. I mean, I do, but not for the board. Right? So first phase, getting to know your patient, collecting the data, all that is nice and beautiful. But for the board, we got 3 phases that we care. One is desensitization. Again, how do you get better at anything other than reliving or practicing the moment? That is desensitization. So when I tell my patient, sit down and let's go back to the moment in which you had the helicopter crash. Describe the phases and identify. So your task could give you a scenario and ask which phase is the patient currently on, right? So if the patient is describing the incident, they are desensitizing, meaning the more you talk about it, the less sensitive you become about it. Okay, so that is the one. Now, other questions would be related to what is your goal during desensitization? Your goal is to ground the patient. Tell me about your traumatic event. I was raped. Sorry to hear that. What time was it? It was 8 o'clock at night. Tell me about the location. It was a dark alley. And then I'll talk the patient through it. They would not have closed eye like I did, right? They'll be looking at the light. And this eye movement triggers the brain. And the more they talk about it, the more desensitized they become. But guess what? It's very traumatic in the beginning. So your goal, as the patient becomes agitated in crisis, is to ground the patient. So how do you do that? Put your 2 foot in the ground, firm, press it on the ground, take a deep breath. You are safe. You did what you could do in the situation. So basically, take a deep breath, in and out. You are safe with me at this location. I'm sorry you went through this traumatic event. Okay? So your goal is what? Stabilize the patient. How? Grounding technique. And doing this desensitization.
You're muted, Dr. Lopez.
Oh, did I just went muted now? Oh,
Yeah,
okay.
just a second.
Okay, I don't know why, but anyway, so your goal is to help desensitizes the patient, but you want to stabilize the patient. So however the patient could de-stress, the therapist will attempt to use deep breathing, ground techniques to decrease the trauma. Once we've done this several times, we talked about the same incident several times in different sessions, we move on to the installation phase. During the installation phase, we replace the negative thoughts with positive one. It wasn't your fault. You did not ask for this. You're attacked. But I was there at 9 o'clock. I was there alone. You did not do this yourself. It happens to you. So we're taking this self-blaming with positive reinforcement. Now, after we've done the desensitization, we talked about it, we did the installation phase with the positive thinking and thoughts, we move on to the body scan. When you first started talking about it, you had this knot on your chest. You couldn't barely talk. Now, visualize your body, look for any tensions, and release those tensions. Move your shoulders, see where those tensions are to help release tensions in the body. Okay, so EMDR stands for eye movement desensitization and reprocessing. Why? To achieve adaptive resolution. Okay, can someone please read this question?
Which of the following is included in evidence-based guidelines as an effective non-pharmacological modality for the treatment of post-traumatic stress disorder?
Right.
A, expressive therapy. B, eclectic psychotherapy. C, existential therapy. And D, eye movement desensitization and processing. My answer is D.
Perfect. Okay, so board question, never pick something that you never heard of. Eclectic psychotherapy, right? That's pretty out there. If you never heard of it, don't pick. Okay, oftentimes that is a trap. If you never heard of it, it's probably not the answer. Why? Because the board always tests on the gold standard. So what else could have been the answer? Almost 100% of the time will be eye movement therapy. Now, if you had exposure therapy, it could be the answer. If you had cognitive behavior therapy, it could also be the answer because it is treatment for post-traumatic distress disorder. However, the board loves EMDR. Okay. Now, what kind of medications can you use for PTSD? Right? You can use your SSRIs, more precisely, Praxil, Prozac. Okay, so yeah, Paxil and Zoloft. I'm sorry, Paxil and Zoloft, FDA approved. Can you use any other? Yes. Okay. Now, what other medications can you use? Not for PTSD, but for nightmares related to PTSD.
Prazosin.
Yeah, Prazosin. Mini press. Yes. Just be careful because that is a antihypertensive medication that will drop the blood pressure. All right. Remember that white piece of paper? If you have not been writing down the 3 things, now is the time. Everything is with an S. Family system therapy, structural therapy, strategic therapy, solution focus therapy, multi-system therapy. Can be super confusing. Okay. 3 things for each. You need to write this down separate in a clean piece of paper because you want to look at this every morning when you wake up so that when you see those things come up, those cues come up on your question, you'll know what is the answer. Okay. So you need to know the goal of dialectical behavior therapy by Marshall I. Ham, which is to decrease crisis. You need to know the goal of EMDR, which is achieve adaptive resolution. You need to know the goal of family system therapy, which is self-differentiation. So what is self-differentiation? Let's say that I have my family, the Lopez family, and my wife and my kids. I am part of the family, but I am my own self. As my daughter would say, Daddy, be yourself. Don't be like mom, right? So it's recognized that each member of the family constitute the bigger family, yet each one of them are individuals with their own likes and dislikes, perfections and imperfections. So you need to know self-differentiation. It's recognized that each person in the family is unique with their own thoughts, emotions that makes them different from one another, even though we're a family. Okay? So under family system therapy, the first thing you need to write it down is self-differentiation. Okay? So this therapy treats the whole families, specifically or especially focus on anxieties and what affects one another. It's about helping each family member see their own role and how they contribute to the family function. What is the goal? Or key concepts, often known as the goal as well for family system therapy, is self-differentiation. Okay, what else you need to put under this bucket of family system therapy? Well, triangles. Let me break this down to you. Triangle is not all bad. Triangle can be good. I know many of you guys get this wrong all the time. Okay? Triangles can be bad too, but can be good. It depends how you use. So triangle, let's go with the good first. Triangle serves to break the anxiety between 2 parties, mom and dad. I'm the therapist, I'm in the middle, so we're bouncing ideas, making a triangle to decrease the confrontation. So triangles can be a good thing. Triangle is a bad thing when we are mom, not mom, I'm dad, and mom, my wife, and I'm using my 7-year-old daughter because I don't want to talk to my wife. That is bad, right? So don't fall for the trap thinking the triangle is bad. So oftentimes the board will ask you which following techniques can be used to decrease the anxiety between 2 parties. And you think, oh no, triangulations is bad because it increases the anxieties and decreases communication. No, right? It depends how it's used. So under family system therapy, self-differentiation, triangulation, which is a way of understanding how 2 stressed family members might evolve a third person to reduce their own tension. Oh, here we go. It can be good to reduce their own tension, which can also lead to complications. It can. But if the therapist is the triad in the third person, it can be a good thing. Using tools like triangulation, self-differentiation, and genogram. If you want to save some brain power, all you need to know about family system therapy, add here who created family system therapy. Bowen. All right. Bowen created family system therapy. Two concepts: self-differentiation and triangulations. Okay. So in simple terms, it helps families understand how they are connected and how each person plays a unique personality and how they affect the family. You need to know the definition of self-differentiation. And you need to know that triangulation can serve to decrease tension. It's not always bad. If I'm repeating, it's because it's important. Okay. So that's the first bucket of that you need to create under the therapy family. Okay. So the next one, which will be 18, as soon as I find it here, 18. Let me open 18, 19, 20. All right. The next one is all right. We did family system therapy. Baldwin is the creator. I would know that for sure. I would put triangulations, and self-differentiation is the goal of family system therapy. The next one is structural. Okay, structural family therapy. It is about structure, just like the military. We need structure. This therapy looks at the family and as a system with different parts, like subsystems and levels of authority. The dad, the mom, older sister, younger sister, the dog. Each one have different levels of authority. We check how the family members connect and if they have a clear roles and rules. That is the part of the boundaries. Like the military, structure family therapy needs boundaries. So guess what? What you need to, I'll get to the three things in a second, but oftentimes we sit down with the family, instead of you saying what the husband did or what the wife did, I say, play it, organize it, play it exactly how it went. Not just telling me how things went, but tell me exactly step by step how this situation unfolded, right? So how the family members interact directly to help them change in a good way. The way the family is organized is important for making these positive changes. So if we look at the goal of it, is you want to change the family structure to help them handle problems better, right? So what are the three things we want to put under structure, right? Boundaries. When boundaries are enmeshed, when boundaries are not clear, people start to step on each other's toes. So with clear boundaries, we help the family set clear boundaries to improve their function. Remember how I said, I sat down and I said, instead of you telling me how this situation unfolded, play it out. So role playing, right? Role playing. And we do a genogram, just like the dad is here, the mom is here, the older sister here, the younger sister, and the dog. Who is what? Like I said, structure. We need boundaries. The genogram is the mapping of the who is who and who does what. And we do role playing, enacting. So the three things to put on this structure is clear boundaries or boundaries, genogram, and role playing, right? So that is it. And we want to do that because when we have clear boundaries, everybody knows the line, right? I say that, I don't know if that matters to you, but when you're in the Marine Corps, things kind of work perfectly. Not because it is better, but because they know the boundaries. If someone steps out of the boundaries, they know they will get punished. But it's not unclear. Should I do it or should I not do it? Right? So structure like the military with very clear boundaries. Okay, if that helps you to remember of structured therapies, the three things you need to know is genogram, boundaries, role playing, enactment of the situation. All right. So the next S is strategic family therapy. So with that, we want to focus on a specific problem and look at the family as a whole. So the therapist gives the family a task called directives and help them achieve their goal. So think of this way. If you are going to take the board exam, these are your tasks. You're going to watch the video, module 1. You're going to complete module 1, question bank. You are going to go back on module 2. You are going to complete question bank number 2. I'm giving directives. I'm being strategic about it. So same thing with the family. When you think of strategic, think of equals to directives. So what are the directives? 3 of them. Straightforward directives. You are going to do X, Y, and Z, and they follow what you ask them to do. These are clear tasks given to the family when they are expected to follow the therapist's guidance. Go home every Thursday and bring a bouquet of beautiful roses to your wife with some delicious chocolate. These are the directives, for example, right? Now, often tested is giving an example and ask which therapy, family system therapy, it is referring to. So under the strategic, it will be straightforward, paradoxal, super high. Paradoxal is when you tell someone to do something, knowing that they are so stubborn and they will not do it, they will do exactly the opposite of what you asked. So if I know John will never follow my directives for strategic family therapy, and if I tell John to go home every Tuesday and argue with the wife, paradoxal directives means that they would go home and bring flowers because I know he will not follow my directives of arguing. So these are tricky instructions where the family is asked to do something that seems to oppose of what they should do. Go home and argue with your wife. It is used when the family member is resistant or unlikely to do what is asked to do. So questions love paradoxal directives. Sometimes they ask, what is paradoxal directives? Sometimes asks, which family's therapy is part of paradoxal directives? And this is why you put in 3 things under each family therapy at this moment. So what do you want to do for strategic family therapy is equals to directives. What kind of directives? Straightforward, paradoxical, and reframing, right? That's when the therapist helps the family see the problem in a new light, which can make sense even more, even more manageable or more understandable. Okay? So in short, strategic family therapy is about giving the family different types of tasks that are cleverly designed to help them work through their problems together. It is like a therapist give a family a set of tools or strategies that might seem unusual at first, but are actually aimed at helping them in the long run. Guys, we're boiling this down to the simplest possible format, right? It's a lot more complex than this. But if you think of strategic family therapy, you think of directives. What kind? Straightforward. What kind? Paradoxical. What kind? Reframing directives. Oh, that is good enough. That is enough for 95% of the questions. You get them right. Okay. So what are the other family therapies that everyone is confused about? If you write down those in a white piece of paper and you look at it 3 things every day, in a matter of 3-4 days, you're going to memorize all of them. So solution. Oh, okay. So strategic, straightforward, paradoxical, reframing. So solution, you want to look at things that are help them in the past to use now. Okay. Is about setting goals and working towards them. It emphasizes using what already worked or working well or strengths and resources to achieve the desired outcome. The key is to find solution that rather than dwelling on the origin behind the problem. In summary, you want something that worked in the past that we can use it now. So what are the 3 things that you need to know for solution focus? We can call it Miralax Coco scale. So which is mirror questions. When you ask the client to imagine a world where the problem has vanished overnight and to explore what change would that bring. If you did not have to deal with this task, how would you feel? Would you start working tomorrow? It's often more complex than that, right? The questions more specific to the problem. We can also do exception finding questions, which we say we're looking for times when the problem wasn't there, which can reveal hiding solutions. For example, I hear that you and your husband are fighting frequently. So tell me about when you first met. What was different about it? I'm finding exception finding questions. Okay? And coping questions that we discover how clients have dealt with changes and highlight their inner resources. However, scaling questions is when we ask the client how bad things are now and ask them on a scales to help them track progress over time. So in essence, solution focused therapy is like being a detective in of the good in someone's life. It's about finding those bright spots where things are going well and using them as a roadmap to navigate out of the problem. And we do this by asking those 3 questions. We say, miracle question, imagine a time in which this problem wasn't present, right? If there wasn't, explore what changed, how would that be in your life if this problem wasn't there? We look at the exception finding questions. We look at the time when the problem wasn't there, and we look for the solution in that moment. What was different about it? And we do scaling questions from 0 to 10. How stressful is the situation now? Okay, so that is solution-focused therapy. Now, something about solution and crisis. Not necessarily about solution, but 2 things that are high. When in crisis, you always divert to what has worked in the past. That's number 1, right? So don't fall, when questions are asked about crisis, don't fall into learning new skills. You always divert to your safe place. What have you done in the past that worked for you? Think of this as also for solution. What have you done in the past to get out of this situation? Can we use those skills? And here, often questions will say an example of miracle question and ask you which therapy it belongs to, or give you a miracle question and ask, is this a straightforward? Is it an example of, give you a scenario and ask you what that would be an example of. So if you don't take the time to memorize 3 things for each one of those therapies, it will be super confusing on the board date. So you have to do this preemptively. You have to be doing this ahead of time. So when you think of a solution, think of a scaling question, miracle question, and exception finding questions. Okay. All right. Let's go ahead. It's 9 o'clock. Let's go ahead and take a quick break, like 10 minutes break. Is that 10 minutes too much for you guys? We're good. Because I don't want to rush through it just for rushing. I want you to absorb. So please walk. Don't stay here. Go to the bathroom. Drink a cup of coffee if that's not going to keep you up all night. And we'll be back at 9:10. Okay, I could just keep on going, but it would do you no good if I'm just talking and you're not absorbing the content. All right, so I'll see you guys in about 9:10, and we'll finish it off very strong, and we're done with module 4.